payments and health care. And this really prompted a discussion about how in our American health system, we could change the way we pay for healthcare. We've tended to pay for healthcare based on volume. The more you do, the more procedures you do, the more you get paid. We haven't been as effective in paying for population health, paying for preventive care, and keeping Americans healthier. So at that time, we articulated what was called the triple aim of healthcare. We said that our goals were to keep our population healthier, to make sure that people in the healthcare system had a better experience of care, and that we said we needed to do that at lower costs. And I think those are universal principles. Those are worthy goals. We've since added a fourth aim, which is that we really do need to do all these things and make sure that we pay attention to the health and wellness of those of us who provide that care. So it's now the quadruple aim. So we know what our goals are for healthcare. We in radiology realized that we needed to get on board with that idea of how we were delivering value versus volume. And our payment system has really incentivized volume in radiology. And we haven't necessarily been, I'll show you some examples, identified as part of the value as much as we should have. So the quote that you see on the top there, our goal is to deliver all of the imaging care that is beneficial and necessary and none that is not, became a rallying cry for us as we thought about how do we make sure that radiologists are seen as part of the value solution? How do we make sure that we're seen as contributing to that quadruple aim of healthcare? And that was articulated by a mentor of mine, Dr. Bibb Allen. And again, I think that's very universal. We never said that this was about providing less imaging. We always said it was about making sure it was providing the appropriate imaging. And whether you're facing, as I do on the Upper East Side of Manhattan, a situation where there's plenty of imaging care available, or as you'll see the other New York example I show, or maybe some of your own practices where you're really managing a more limited set of resources, it's important that we focus on appropriate imaging and make sure that we are not doing imaging that doesn't add value to care. As we thought about how we would achieve that goal, there were three things that we needed to focus on. And the first was culture change. I'll talk a little bit about that. The second was making sure that we had the right kind of tools to enable the change. And that's critically important. And we'll talk a little bit about how I see artificial intelligence as contributing there. But the last thing is that we need to think about how we incentivize care, how we pay for care. What are the policies that we enact that either drive us in the right direction towards that quadruple aim, or potentially frustrate us and send us in the wrong direction. So as we thought about this change, we realized that we had some work to do to remind people that we were even in the delivery system. Through innovations like PACS, we had really become invisible to the rest of the care team. And I'm hoping that in many of your institutions, that's not the case. But certainly when I was a trainee, we would always consult with radiology. That was very much part of making decisions on patients. But once we had PACS where we could read the cases from anywhere, we started to have less and less interaction with our other clinical colleagues, and certainly rarely, if at all, with our patients. So we had become somewhat invisible. We had tried through the American College of Radiology to do public relations campaigns to talk about the value of radiology. We'd spent a fair amount of money on them, but didn't really feel like they got much traction. And we would see articles like this, that many patients didn't even know that radiologists were physicians. They would think perhaps that the technologist who obtained the images was the radiologist, or that the physician who referred them for the images was in fact the one who interpreted them. So we had a branding and we had a perception problem. An important thing that we had to think about was how we have, in many ways, set up our systems and our workflow and our incentives to benefit us, to suit us as physicians. And we've rarely thought about what's meaningful for the patient. And this is a colleague of mine, Jim Rawson, one of our ACR volunteers, who gave us this quote that we used really to inspire us, that it's hard to put the patient at the center when you're there yourself. So as you think about value, it's important to think about that from the patient's point of view. What's the optimal way for them to get their care? And we went through this journey of thinking, well, we've been very well intentioned towards our patients, but essentially the old-fashioned model is that we're doing to our patients. What we need to think about is a journey towards really sharing with our patients and understanding their goals for their care. That's not easy, it's time consuming, and it's something that not only we, but other physicians struggle with, but we need to be sensitive to what it is that our patients see as value for care. So as we thought about the culture change, we did a lot of research in the business literature, thinking about how we're 38,000 radiologists in the ACR. How do you make change at that level? And there are a number of theories out there. Do you create this burning platform that something is, imminently very wrong? We decided that wasn't the way we wanted to go. We decided that we would tap into our community and look for champions of change. Look at people who are already doing something different, something more focused around patients. And something I remember saying at the time was, everyone's not going to change the same way. Everyone's not going to change at the same pace. What we need to do is celebrate success, find inspiration in the stories of our community. And we certainly did that. We have collected, I think, about 100 stories now of people who've reshaped their practice, who've made new connections, who've changed the way that they deliver care. These are all collected on our ACR website. They are freely available to you all. Please check them out. There are some really inspiring stories, and I'm going to tell you a couple of them. So the two stories I'm going to tell you are both located in New York. One of them is at my own institution on the Upper East Side of Manhattan, and one is in Queens. And on this map, it shows that we're not that far apart, depending on the traffic, which is often very bad. We're about 45 minutes apart. This is my hospital, New York Presbyterian. It's a beautiful institution. It's right on the river, and we're very fortunate to have our location and our beautiful home. And this is the other hospital in Queens, Jamaica. And if you've been to New York and you've flown out of JFK, you would have passed this hospital. It's not quite as beautiful, and it's has a lot more challenges financially. So even though we're in the same city, things look very different. So on the Upper East Side of Manhattan, where I practice, the median household income is 300% the national average. Whereas in Queens, 30% of the population lives in poverty. We have many more physicians on the Upper East Side of Manhattan, not as many in Queens. And even in a relatively diverse city like New York, the Upper East Side of Manhattan remains relatively undiverse. Whereas, and I just love this statistic because it's everything that I treasure about the diversity of New York, that 56% of the Queens population over 5 speaks a mother language other than English. In the interpreter system at Jamaica Hospital in Queens, I believe they have 500 languages in their database. So in the same city, but quite different practices, but yet so similar in the commitment that we've made to our patients. This is our former dean who talked about the need to put the patient at the center of everything we do. And the mission at Jamaica Hospital to serve our patients and our community in a way that is second to none. So let me talk a little bit about my practice. And I will say that a lot of these changes were made as or before I joined the faculty. I think small things matter. This is our website, and you'll see that the patient box is at the top. We're telling our patients they are the most important thing to us. Changes like this need effective leadership. This is our chair and vice chair, Dr. Min and Dr. Hentel, who've been really instrumental in this leadership. We do some other things too. This is walking into one of our imaging centers, and there is a big screen as you walk in that says, if you'd like to speak to the radiologist, we're happy to speak to you, just let us know. It also tells the patients who are the doctors who are reading their studies that day, who's the neuroradiologist, who's the body radiologist. We want to be visible and available to our patients. Another thing that we're doing, we have a law in New York, as do many other states in the US, that says we have to notify our patients if they have dense breast tissue. We know that dense breast tissue confers an increased risk of breast cancer and can make the mammogram harder to read. So sometimes we'll supplement mammography with ultrasound for patients with dense breast. That law went into effect in 2015. And a lot of women had questions about what does dense breast tissue mean? And their primary care physicians equally were a little baffled by how they should talk about this risk. So what we did was, on all of the reports that we sent out to doctors and patients, we put a telephone number and an email address so that if they have questions, we are happy to talk to either the patients or their doctors. We also make all of our patient reports available on an electronic portal. Sometimes we'll put a little delay in. Certainly if there are significant results around a patient with cancer, we want to make sure that their own doctor has an opportunity to see those results and talk to the patient first, rather than just reading it on a website. But you can see again on the portal that you can see the phone number and the email address. And the person who manages that consultation service is what we call a radiologist assistant, who's a technologist who's received some additional training, and they're able to connect either the doctor or the patient with any other service in the institution that they need to help them get the answers they want. Now, I'm often asked about our consultation service. Well, doesn't it take a lot of your time speaking to patients about their questions? We did some work to look at the actual time, and you can see that the radiologist assistant spends most of the time with the patient. And if I'm a physician getting a call from a patient, my colleague prepares me with, what's the patient's question, gives me the record number. So the time that I have to spend with the patient is usually very, very short, but it means so much to help those patients understand what's going on with their mammogram and answer their questions. We've written about this in a number of different papers, and we can certainly send those links. And we were very fortunate. We won an award, a patient-centered imaging award from Health Imaging Magazine. And these are my wonderful breast imaging colleagues at Cornell. So now let's go across the river to Queens, because we are very fortunate at Cornell. We have great resources. You could say, well, it should be easy for us to do these kinds of things. We are a big academic medical center with a lot of leadership support and a lot of resources. So I tell this story. I'm sitting in the reading room one day, and the phone goes, and the operator says, there's a doctor from Jamaica Hospital who wants to speak to you. So this is Dr. Sabiha Rauf, and she gets on the phone and she says to me, I want to make my practice more patient-centered. She said, I'm the chair of radiology at Jamaica Hospital. What more can I do? So I talked to her about, I think I'm going to tell her about all of the great ACR programs that we have. We have registries that can report your dose. We have a clinical decision program that can enable more appropriate imaging. We have accreditation programs that can allow you to demonstrate your quality to the community. We have leadership training. Well, it turns out she was already doing all of those. She had already embraced all of these important change agents and tools, even in a resource-constrained setting. So what I said to her at that point is, let me be a little bit more humble. Let me ask you what you're doing, because I think I can probably learn a lot from you. So what she told me was so inspiring. Sabiha diagnosed her own breast cancer. She's a radiologist. She's a breast imaging radiologist. And as she was going through her treatment, she realized how different all of our processes feel when you're the patient and not the doctor. And in telling her story about the way in which she had created what she called making a difference rounds, where she would go around the hospital every day with some of her colleagues, different colleagues every day. Maybe it was someone from accounting, maybe it was someone from engineering, maybe it was another physician, and simply ask the patients in the hospital, how can I make your experience better? She said, I needed to connect to the people whose images I read, making herself visible, equally powerful, and really just an amazingly inspiring story. Now, I will say that as we started these efforts, there were questions from many people about whether it was even appropriate for radiologists to speak to patients. We're all preparing for RSNA here right now. And I remember in 2013 at RSNA, we had a tweet chat. And how many of you are on Twitter? Love to see you on Twitter. Bhavya and I are both very active there. But we did a tweet chat at RSNA, and we asked the world the question, what does value in imaging mean to you? And we specifically wanted to know from our patients, We specifically wanted their opinion on what they wanted from us as radiologists. And what we heard loud and clear from our patients was, I want my results, I want them quickly, and I don't really mind who gives them to me. I want them from the first person that can give them to me. And that was very interesting for us. Now, as I say, we are very aware that we don't want to give patients results without involving their other physicians. And sometimes there are going to be questions that the patients ask us that we simply can't answer. That's why it's so important for us to be working as part of a team. So, we did a lot of work with sharing success stories and getting our message out in the wider world on culture change. And then the next thing we had to focus on was informatics tools. And when we think about artificial intelligence and what it might mean to really enable radiologists to be more visible, more valued, and have more time to connect with patients, we don't just think about AI algorithms that can read the mammogram better than a radiologist, as if that is even going to happen anytime soon. But we think about all of, and we in the US have a very burdensome, I would say, administration around billing and compliance and record keeping. So we see many opportunities from every step through that the patient takes through their imaging journey, for us to be able to use informatics and IT tools to make the experience better for the patient, to make sure that we're able to provide better care, to make sure that we keep the costs lower, and also as providers to make sure that it's a more satisfying experience. So AI tools and other informatics tools for us go far beyond just some of the algorithms that we're hearing about that'll be applied to the actual images. We think there are many opportunities. We see artificial intelligence as just one more tool in that armamentarium. The last thing I want to talk about is how we decided to try and influence healthcare policy in the US to support this change. So you remember the quote at the beginning? We need to do all of the imaging that is appropriate and necessary and none that is not. We had developed a set of appropriate use criteria for what's the best imaging to do in a particular clinical scenario. And we took those criteria and we first of all made them electronic, and then we next embedded them in our commonly used electronic health record systems here. What we did then, which was really important, was we influenced our Congress to pass a law that said that people who were ordering imaging tests in our Medicare program, which is our national insurance for the elderly, and it's important that it starts there, that tends to influence healthcare policy across the entire country. But this law said that anyone who's ordering what we call an advanced imaging test, CT, MR, or PET, in this program would have to consult a tool to decide, are they ordering the best imaging? Are they ordering the most evidence-based and appropriate imaging? So not only did we change our culture, not only are we looking at tools to support that change, but we are also influencing policy. We're making sure that how we get paid and regulated is about the best imaging care. The other thing we did, one of my favorite quotes about leadership comes from a guy called Ron Heifetz at the Kennedy School of Governance at Harvard. And he says, attention is the currency of leadership. So by paying attention to patient and family-centered care, we have shown that it's important. We have created what we at the ACR call a commission. And by creating a commission, we've put resources, we've put staff, and we created this commission in 2015 to show the rest of the world we're serious about putting the patient at the center. The chair of that commission, the person who's leading that commission, is the same Jim Rawson who gave us that quote, it's hard to put the patient in the center if you're there yourself. So I'd like to think that as a specialty in the US and as a society, we have really refocused around what's meaningful to our patients. And we've set this goal for ourselves as an organization, that ACR members are universally acknowledged as leaders in the delivery and advancement of quality healthcare. It's important to realize that says we want to be recognized not just by other radiologists, but also by every other stakeholder in healthcare, our patients, other physicians, policymakers. We want everyone to know that we're committed to high value, patient-centered imaging care. And as I say, we're a big society, so when we speak, we have influence, but it's important that we use our influence in the right way. We also have a very diverse community in the US. As you saw, mine and Sabiha's practice are quite different, even though we're in the same city. We have practices in big cities like New York. We have practices in tiny, tiny rural areas. We even have radiologists who practice solo. So it's important for us, again, as we influence policy, to think about how we can make change in all levels and in all practices, which is why it was so important for us to collect those success stories from around the country to show that change is possible in all settings. Everyone's not going to change at the same pace, and everyone's not going to change the same things, but we can all make changes to bring our practice more towards having our patients at the center. I want to go back briefly to the fourth aim, the well-being of providers. And I don't know about where all of you practice, but physician burnout is a huge topic here in the US right now. We unfortunately see far too many physician suicides, and we see physicians leaving the profession because they're simply so burned out and so unwilling to keep engaging in the practice of medicine. So we're really focused on how we can support our members and really bring joy into our practice. We recognize that a lot of the tools that we use to enable productivity, whether it's things like PACS or whether it's the potential of some of the new AI tools, we feel like we have the opportunity to either drive more productivity, work even harder and faster, or we have the opportunity to step back, find more time for our patients, find more time for our own self-care. We've made tools available to our ACR membership to help them assess where they are in terms of burnout and go on the important journey of finding joy in their practice. I don't know how many of you have ever watched I Love Lucy. It's a pretty iconic TV show that many Americans grew up on, and this is a very famous scene where she's working in a chocolate factory and she just can't keep up. She keeps eating and she keeps packing and she can't keep up. And I show this slide, and it always resonates with folks here in the US. But I think this is the choice we have to make. If AI tools can make us more productive, are we going to use that just to read more studies, or are we going to use that to be more effective and efficient so that we can spend more time with patients and spend more time consulting with the other physicians on the team? We certainly have some challenges in the US in terms of healthcare spending. We know that we spend more than any other developed nation on healthcare, and we don't always get the results that we need to. We're getting close to spending 20% of our national output on healthcare. So we certainly need to make sure that we're adding more value to our healthcare system. So, I think as I look at where we are at the ACR, we've gone on an important journey since 2012. We are continuing to look for new payment models and incentives that will drive more patient-centered care. We continue to look at that goal of being universally recognized for the value we deliver, working on relationships with other radiology societies, with other influences in the US, and increasingly with many other stakeholders around the world. And that's very exciting work for us. I think we're taking care of each other better, and we're recognizing that we have to do that. And we are really excited about what AI can do for us. We established a data science institute 2 years ago. We're working on ensuring that the AI algorithms that get applied to imaging are safe, that they're effective, that they protect our patients, that they do not have bias, and that they preserve the unique value that human radiologists can bring to our work. And then lastly, through our research efforts, we are excited about discovering the future. We do a lot of research at the ACR, whether it's in large clinical trials to understand what the imaging of the future will look like, but we also do a lot of health policy research to understand how we can best shape care going forward. Now, everything's not always rosy. We do have some incentives to pay for higher value imaging care, but they're not they're not as meaningful as they should be, and it's quite burdensome to participate in them. So our signature landmark program of requiring physicians to consult our appropriate use criteria has actually been delayed by Congress and the agency that is delivering it. We're actually looking at some significant payment cuts through some things that have happened in Congress that are really nothing to do with us. We're sort of collateral damage, so we'll have to fight those. And our practice landscape in the US is really changing. In the past, people worked in either academic institutions like mine, or they would work in private practices where they contracted with hospitals to deliver their radiology reading services. What we're seeing across the country is large corporations buying radiology groups and hiring radiologists. Now, I'm not going to weigh in on whether that's a good or a bad thing, but it's definitely meaning that the choices that our trainees have coming out are different. And it's really important for us to make sure that we preserve the important things about our practice, all the things I've talked about, being able to spend more time with patients, being able to have joy in our practice. We must fight very hard to not just preserve that, but also in many cases increase it. And as you know, we live in a world that is very politically unstable. We are heading into an election year in the US. What that means for us as we try to influence policy is that when Congress is focused on the election, it's harder to get some of the more routine work done. So we have to navigate those challenges. And then the last thing I would say, if I'm thinking about some of the things that that I feel like we still have to deliver on, is that our profession is still not as diverse as it should be. Bhavya mentioned that I'm the first woman to be chair of the American College of Radiology in its almost 100-year history. Yesterday was Marie Curie's birthday. We have not really delivered on the promise that she showed us of women in science in terms of their inclusion in radiology. We're still in the US at about 25% women. Now, I know from speaking to many people around the world that there are countries that are doing much, much better than that. We also lag significantly on ethnic diversity. We have a lot of work to do there. And believe me, we are committed to doing better. But I think you can always look at both sides of the coin. I tend to be an eternal optimist. I'm so excited for the future of our profession. I think the changes that we've made, refocusing on patients, and the way in which we've shown the world that that's our priority, and not just shown the world, but gone to policymakers to say, we want you to pay us for quality. We want you to pay us for the care that we take of our patients. I feel very fortunate to be in radiology at this time. And I'll leave you with this, which is, we are many thousands of miles apart on this International Day of Radiology, but this is what we share, right? We share that we are here because we want to make our communities better and we want to help our patients. So I'll stop there and say happy International Day of Radiology, and it's been an absolute pleasure and privilege to speak to you this morning.
Thank you so much, Geraldine. This was an excellent talk. Really appreciate this. Inspiring, and I'm sure our audience just loved it. I think we can take questions right now. We are very lucky to have Geraldine here with us. So if you have any questions right now, please feel free to ask. We have University of Rwanda who could join us too. And let me unmute them. So Ivan and everyone else, if you have any questions for Dr. McGinty, this would be a good time. Anybody at Mohindali? Any questions? Anybody from Rwanda? Any questions? Ivan and the team, Dr. JJ.
Well, Bhavya, maybe I can ask a question.
Okay.
I'd love to ask. First, I'd love to ask, what are people doing to celebrate International Day of Radiology?
That's a great question, right? So, Dr. Ahmed Yousabani, you're the one who brought this up. Do you want to tell us?
Thank you so much. I am Dr. Ahmed Yousabani, Assistant Professor of Radiology at Aga Khan University. Unfortunately, I was traveling from South Africa and just arrived this evening. But I know my colleagues from Muimbili University and Muimbili Orthopedic Institute had organized a day symposium discussing on musculoskeletal imaging. Uh, but I would like to comment about this lecture, and I think it is absolutely appropriate on this day. If you look at the radiographer's theme for this year, it says, "Your safety, our priority." The radiographer is promoting and maintaining safety culture. So I think this is an absolutely appropriate lecture on that. We, being a private institution, we are the only Joint Commission International accredited hospital in Tanzania and among the 10 in the whole continent. So for us, it's absolutely necessary to have patient-centered care. As you guys will rightly know, that there are two chapters of Joint Commission which deal with patient and which are patient-centered. There's patient and family education and patients and family rights. And I truly believe that patient-centered care has a huge impact. It improves patient outcomes, eliminates potential life-threatening errors and safety problems, improves organizational, clinical, and structural competence. But overall, it empowers patients to participate fully in the disease prevention, management, and healing, regardless of the culture or whatever background they have. And we have put several strategies in place. I am also the chief of staff for the institution, and we have shown a committed leadership in patient-centered care. We support a learning organizational culture. We develop staff, build the capacity, and provide a supportive working environment. We always engage patients, family, and carers as partners in improving care. And we do collect some data, and we are implementing patients' right charters. In all these ways, I think we are truly engaged in patient-centered care. So this is just a comment, no question.
No, that's terrific, and I think you touched on something that I probably should have spent more time on, which is I think that patients who are engaged in their care, I think, are much more likely to get the appropriate follow-up. I mean, I do breast imaging, and regularly have discussions with my patients about how often they should be screened and when they should start screening. And those are the opportunities that we have to really impact outcomes when we are engaging with our patients.
I completely agree with Geraldine and Dr. Jusabani. That was an excellent comment, and thanks for saying that. And that also on the International Day of Radiology, as Geraldine said, our patients are our focus, and Geraldine has done an excellent job promoting that with Imaging 3.0. She was the main force behind it through the American College of Radiology. Any other questions? I heard something from Mohimbali side. Any comments or any questions?
May I ask, how would ACR be able to support, especially the public hospitals in the country? Because in private hospitals, maybe we are getting there, but public institutions maybe need to be supported on this agenda. And how would ACR be willing to support?
So we have members from all types of practice, and we don't, obviously every country probably defines things like public hospitals differently, but many of the public hospitals in the US are linked to academic hospitals. So, they are part of our education mission, and, but we do understand that, they can be very, again, resource constrained. But I think that's where Sabiha's story is so powerful, because these changes are often possible just by committing to the culture, committing to that commitment to that mission. Now, I think that we also we need what we've tried to do is make sure that for some of the programs that support things like poor children, that we're advocating very strongly for appropriate reimbursement for those programs. So, you know, we do it again. It's the same three things. It's the culture change. It's making sure the tools are there, and then it's making sure that the payment policy is what it needs to be. A lot of my research is on making breast cancer screening more accessible through changes in the way we pay for it. We definitely we're interested in making change throughout the entire system of care in the U.S.
That's great.
You talked about two things. One was clinical decision support tools and leadership training.
Mm-hmm.
Is there a possibility for members in the resource-constrained countries like us in Africa to have access to this at a lesser cost or at a free cost, free of cost?
So our appropriate use criteria are on our website. They're free. You can access them for free. We do have a web portal. I'm not sure if it's available yet outside the States, but we've been working closely with the European Society of Radiology, and I think, and we can take this offline, I believe they've been working closely with some of the African radiology societies. So Fabia, let's take that question offline. In terms of the leadership training, we have a lot of, we have our radiology leadership organization. A lot of that content is available on our website and on our YouTube channel. So please check it out. I mean, a lot of my lectures are on there. You know, we do try and make sure that that we make that stuff available. So the ACR's website and our YouTube channel, check out.
Okay, thanks.
And Mohim, I think there's a question. You guys want to speak up? We can't hear you. Give me 1 second. You guys are not mute. Let's see. All right, can you try again? I'm sorry about that.
Do you want to try typing in the chat function?
Yeah, let's try chat. You want to type in on the chat function at the bottom on the Zoom screen? We can try that. And the other option is coming close to the laptop. Sometimes that works too. Yeah, so you can type it in the chat box at the bottom. And the team from Rwanda, if you have any questions, you can also type it in the chat box.
I think while the colleagues are doing that, my take-home message would really be that we stick to the core elements of quality care as by WHO, those are being said. And we have to remember STEP. It has to be safe, timely, effective, efficient, equitable, patient-centered care. And by equity, we mean that having equal resources, but not only having equal resources, but providing resources for equal opportunities for all our patients.
Yes, absolutely. We are absolutely committed to making high value imaging care accessible and available.
All right, so I think Mohim is typing the question. And Ivan, you can also send it to me through WhatsApp right now, if that works better. Geraldine, this was an excellent talk, inspiring, very, very, and I think it was great on the International Day of Radiology for the worldwide audience. So this was perfect.
Well, very excited to be here and really sort of inspired by the work that you're doing.
No, it's just a group effort. It's not just me. And you are the world stars, you know.
Okay, I'm dying for this question now.
I love to see the smiles in Mohim Billy. If Dr. Jacob is there, she can also contact me on WhatsApp. or call me on WhatsApp. We can also conference in like that. It's a long question, right?
And certainly, Bhavya, if anyone has any follow-up questions and specifically about ACR resources that might be available, please send them my way.
Okay. Geraldine, so the question is here. Thank you for a good presentation. I want to ask on patient healthcare about increasing relationship between a patient and the radiologist who's supposed to give a report to the patient? Question mark.
So that's a great question. It depends actually in the US on what type of study you're doing, because with breast imaging, with mammography, we're actually mandated by the government for the radiologist to give the result to the patient. And that's been in place for more than 20 years. So as a breast imager, we're very used to talking to patients. We also have a responsibility, once we've recommended a biopsy, to follow that patient through until that's done. That responsibility has not been as clear for other physicians. And I know many people, as I said in the talk, wonder whether it's okay for radiologists to talk to patients, and what if you're telling the patient something that they don't know, that they ask you a question, you don't know the answer. What we've found, and you know, obviously we do this in my practice, the patients can ask to speak to the radiologist, is that, you know, if there's a question you can't answer, you say, I can't answer, and I'll be in touch with your physician and we'll get back to you. But patients want to know their results as quickly as possible. They don't want to wait, especially our patients who've had cancer. You know, it's every minute is agony for them. So whatever we can do to minimize their anxiety, we should do. So I feel very comfortable with radiologists talking to patients. I do feel, though, that radiologists have to be very tightly connected with the clinical team that they work with, so that, you know, obviously if there's an unexpected finding, you're not going to just send that patient home. You want to make sure that they're going to get the care that they need.
Fully agree with Geraldine. And, you know, as Geraldine said, there are some subspecialties in which you don't have that much of patient contact. I'm a neuroradiologist, so we do not, you know, routinely interact with our patients. So we have neuroradiology rounds in which we partner with neurologists and just go in the ICU and talk to the patients and the families with the neurologists on our side, you know.
Right.
And as Geraldine is saying, because you shouldn't be the one giving the bad news, or you have a stroke, you know, and then without involving the neurologist. So if the neurologist is there and you are there, you're showing the image, they're helping you out, you know.
Right.
So that's a perfect.
It has to be a team. It has to be a team approach.
Exactly. All right, that is excellent. Any other questions? Okay, I think that is it. But thank you so much, Geraldine. This was excellent. And happy International Day of Radiology. And I really appreciate you doing this for us. Thank you.
Thank you all. Thank you for listening. Take care.
Take care. Bye-bye.
Bye-bye.
Thanks.